topics related with labor and delivery. In the last session, we discussed breech, and before that, it was instrumental delivery, particularly not instrumental only, but it was a forceps delivery, because in instrumental delivery, then we also need to take up ventouse delivery, and a better terminology for both of these would be operative delivery. But I also thought that care of normal labor or conduct of normal labor is generally taken for granted. And I personally think that that is something which is very important, because most of the patients, most of the women at the end of their pregnancy expect to be delivered normally, and they do deliver normally, because the cesarean section rates, overall cesarean section rate still is in the vicinity of about 30%. As a matter of fact, if we take all the women who give birth in, say, Pakistan or countries like ours in developing countries, then the number of cesarean sections, or the percentage of cesarean section overall, not taking only the hospitals, overall would be in the vicinity of less than 20%. The reason for that is that if you take into account the domiciliary delivery, the deliveries taking place in the periphery, then the number of cesarean sections which are actually required would be less than would be optimal number. Optimal number, according to some standards, according to WHO calculations, would be minimum of 15%, because 40% of labors will have some kind of issues, not necessarily serious ones, but the rate of complications is 15%. वैसे तो ये भी ठीक है, इसके थ्रू ही करते रहे तो ये नहीं ठीक, ये आ रहा है ना आपको सबको नजर, तो मैं जब वो करूंगा तो भी ये ठीक है, ऐसे ही चलने दें, सबके पास है, ये बेशक बंद कर दें। ये जब मैं शेयर करूँ, हाँ आपको उसकी जरूरत होगी शेयर करने के लिए, उसके साथ कर दें। So therefore, if you take into account all the deliveries taking place in the periphery and all that, the number of cesarean sections overall for Pakistan perhaps would be less than 15%. Anyway, and on the other hand, if you look at women delivering in hospitals, the number of cesarean sections is higher, and probably more so in private hospitals. My own cesarean section rate, which I don't like, is higher than I would really want it to be. Although I personally favor as much as possible normal delivery. Now, coming back to normal delivery, if you just sit back and think about for a while that the importance of, say, obstetrics, our subject is obstetrics and gynecology. And if we look at it, half of it obstetrics, half of it, let's say, gynecology. But the whole purpose of obstetrics is culmination of pregnancy and culmination of that pregnancy. And that culmination of pregnancy is in the form of birth of the baby. And the objectives of good obstetrics are that a woman should enter into pregnancy in a healthy state of health and good health, number one. During pregnancy, her health should not deteriorate. As a matter of fact, it should improve because it is being monitored. So if she started with less than optimal hemoglobin, the hemoglobin should improve. She would have the opportunity of having been screened for a few diseases like diabetes, abnormal glucose levels, or blood pressure, or some underlying other conditions, because she is having on a periodic basis some medical checkup, which is in addition to assessment of well-being of her pregnancy. And so therefore, you take measures, you institute treatments which will gradually make her health better, so that at the time of delivery or approaching the term, she should be in actually optimal health to deliver the baby and in a better condition than probably she started her pregnancy with. So therefore, that is the objective. And then ultimately, she should have a normal birth if it is not contraindicated, and then it should result in the birth of a normal, healthy baby. So the objective of obstetrics overall is that a woman should enter into pregnancy in a healthy state, which is pre-pregnancy planning or pre-pregnancy counseling, etc., if the health systems would allow that. And then during pregnancy, her health should improve, and it should ultimately result in the birth of a normal, healthy baby. So that is overall obstetrics. And this is the specialty through which the human race is progressing. If there weren't obstetrics, if there wasn't delivery, then of course, human race would be finished. It'll be extinction. So therefore, I think this is the importance of obstetrics, and this is the importance of delivery and labor, etc. Now, coming into the technical aspects of labor, I'll share with you a few things. Share screen करनी है मैंने, वो allow करें. अभी नहीं हुआ, डिसेबल्ड अभी. The topics and presentations that I have, I think that we'll have to take 3 sessions on this. उन्होंने कहा प्लीज मेक होस्ट डॉक्टर फरूख जमान. इनको आप कर रहे हो इमरान को. पहले तो ये हो जाया करता था इस तरह से. सर ऑटो नहीं होता, वो एक असाइन करना पड़ता है जब भी मीटिंग स्टार्ट होती है. ये किसने, आपने मैसेज दिया हुआ था? अच्छा. चलिए उतनी देर तक फिर ऐसा करेंगे, फिर आप मेरी स्क्रीन को ही शेयर कर दें. वो ये है अभी जो वापस था जैसे पहले था, आप उसको निकाल दें तो मेरी स्क्रीन शेयर वैसी हो रही थी. मैं ये शेयर उधर नहीं हो सकेगी, पार्टिसिपेंट पहले हो रही थी जूम, ये अगर उसको निकाल दो तो फिर मैं कर रहा था तो हो रही थी उस वक्त. अभी की बात करें? हाँ अभी की बात है ना, ये देखें ना, ये अगर मैं इसको इस तरीके से इस्तेमाल कर रहा हूँ
जी सर,
तो ये शेयर हो रही है इस तरह से।
सर राइट्स तो है नहीं, वो अभी अभी फिलहाल तो मेरे ख्याल से कोई राइट्स नहीं है।
आप लोग ये स्क्रीन देख सकते हो आप लोग
सिर्फ आपकी वीडियो
जो जो
जो
नेट पे हैं, कैन दे डू दे सी मी और दिस
Yes,
स्क्रीन?
yes, sir. You are visible. You are visible, sir.
All right, let me show you my. Okay, I don't know whether I'll be able to. वो स्क्रीन शेयर नहीं होगी।
ये लाइव होने के बाद भी ऐसे ही चल सकते हैं जो इधर चल।
ओके। हाँ जी, वो तो आ गया है नजर, लेकिन मैं तो करना चाह रहा था, वो दिखाना चाह रहा था ये। एनीवे चले मैं वो पढ़ना शुरू करता हूँ। ये इन 2020 दिसंबर वर्ल्ड हेल्थ ऑर्गेनाइजेशन। हाँ जी, इमरान शफी आप जरा मुझे वो कर दें, उस पे जरा को होस्ट कर दें। इमरान ने उठाया था, उसने सुना ही नहीं है, उसने बंद कर दिया फिर।
सर बना
Oh,
दी आपको को।
ओके ठीक है, आ गई, ठीक है। ओके, कौन सी वाली थी जो मैं करना चाह रहा था? मॉनिटरिंग। Now, we'll briefly go through this. This is monitoring childbirth in a new era for maternal health. I'll not go, I'll not read it up all, but in 2020 December, WHO came up with improvement in its directions for management of labor, WHO labor care guide, new tool, WHO recommendations on intrapartum care into practice, labor care guide users manual. These are documents which are available on the net, and as health personnel are encouraged to regularly assess the well-being of the woman and her baby, record their observations, check for signs that breach thresholds for health and well-being as labor progresses, plan what care may be required in consultation with women, and beyond the partograph, a revolution in maternal health, quality of care, etc., etc. So these were the things which were included in this new labor care guide. Now, I'll briefly talk to you about labor management. The gist of what the labor care guide as given by WHO is depicted in this particular infographic, which says essential physical resources which are required for a respectful maternity care. And it also shows here that it should be there should be competent and motivated staff, and the components of that are respectful labor and childbirth care, emotional support from a companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation of events, audit and feedback, oral fluid and food intake, mobility in labor and birth position of choice, pre-established referral plan, continuity of care. So these are the 9 various components of labor management in at various levels. When we say levels, that means if it is in primary care, or it is in secondary care, or it is in tertiary care. All of all of these components, they apply in tertiary level. Some of them apply in primary care, because if the labor doesn't go well, then the woman is shifted or transported to another care with better facilities. These are some of the important aspects which need to be taken into account, that more than 1/3 of maternal deaths, half of stillbirths, and a quarter of neonatal deaths result from complications during labor and childbirth. So that is the importance of proper care in labor and proper monitoring of women who come in for giving birth. Majority of these deaths occur in low resource settings and are largely preventable through timely intervention. Now, most of us are working in tertiary care hospitals. Those who are getting training, they also are getting training in tertiary care hospitals. And therefore, most of them, they may not be aware of the constraint of resources which would be there in primary health care, say in a basic health unit, or like many women, they deliver at home by traditional birth attendants, and what kind of monitoring would there be? So therefore, they are prone to suffer from complications, and those complications may go unnoticed for variable period of time. And you know about those 3 delays, which in many developed countries, they are no more there, but they are very much relevant in countries like ours. Can anyone name those 3 delays? If yes, you can raise your hand, or you know them. 3 delays. One is, first is to make a decision about referring the patient to a better facility. Taking that decision, if it is taken for too much time is taken for that is the first delay. Then getting the transport, managing a transport and taking it, because a motorized vehicle may not be appropriate, vehicle may not be available. So transporting a woman from that place where she is laboring to a place where her complications will be addressed, that is the second delay. And the third delay is, even after she comes to a tertiary care or a place where her complications can be handled, there may be a delay in diagnosis, in instituting those interventions. So those are the 3 delays which result in increased morbidity and mortality. So therefore, monitoring of labor and childbirth and early identification and treatment of complications are critical for preventing adverse birth outcomes. Similarly, improving quality of care around the time, that obviously improves the outcome. So in 1994, WHO devised a partograph, which is given in this. I'll show you this in greater detail, but a little bit of history of partograph. What is a partograph? It is a graphic recording of progress of labor and salient conditions of the mother and fetus as you monitor them. And since 1970, it detects a labor which is not progressing normally, indicates when augmentation of labor is required, and it also would recognize if there is undue delay, perhaps because of cephalopelvic disproportion. And because you people may not have seen obstructed labor. I have seen obstructed labor in those cases when the baby is mostly dead. The external genitalia are swollen, and the head is stuck at the brim. Half of it is in the pelvis, half is above that. Uterus is contracted. The woman has tachycardia, she has pyrexia, she is dehydrated, and all those signs are there. And that's a desperate kind of situation. And you can imagine that if a woman has been in labor for a longer period of time with obstruction, then the lower segment, how thin would it be and how prone it would be to rupture. So if you go along a partograph, that would, and this partograph is meant not only for doctors, it is meant for all those who are involved in delivering the baby. That may be a midwife or a middle level care person for delivery. Partograph was conceived in 1954 by an American obstetrician by the name of Emanuel A. Friedman. And he divided or coined the terms of latent phase of labor and active phase of labor. And at that time, the active phase was considered to start, and till recently, active phase was considered to start at 3 centimeters cervical dilatation. So the latent phase is of 8 to 10 hours, according to that, in which there is the contractions become more frequent, become regular, rhythmic, and painful, etc. And the cervix also becomes soft and it starts to dilate. Up to 3 centimeters, one would call that latent phase, and then onwards, according to that, if you look at that partograph, which we'll see again, it'll be the active phase. And this is the work which was the foundation on which others have improved. Now, this is again a graphic representation, a kind of old picture, because this is the original one. So if from 0 hour it starts, this is the cervical dilatation, this is the time duration. It starts and the latent phase goes up to, say, about 10 hours, during which the cervix dilates up to, you see, 3 centimeters. And here there is an accelerated phase. So in about 2 hours or 3 hours, from 3 centimeters, it goes almost to 9-10 centimeters. And then there used to be called that deceleration phase. So phase of maximum slope in which that rapid dilatation occurs. And they thought that primigravida and multigravida did not have any significant difference in that dilatation. So it's important to understand that. And if we take the upper part of that partograph, original, in 1972, this concept of alert and action. So up to this place, that is 8 hours, it is up to 3 centimeters. This is the latent phase in this graph. And onwards, one would expect the labor to speed up in, say, about 90% of primigravida, because those were the women that particularly were included in the study. And in next about, say, 6 to 8 hours, the cervix would be fully dilated, because after 3 centimeters, then if it dilated at a rate of 1 centimeter per hour, so in 7 hours, it would dilate to 10 centimeters, and that would be normal. But if it doesn't, or if the rate of cervical dilatation is not 1 centimeter per hour or less than that, and so much time has passed, so that is something to then be vigilant about. So you start looking at why the labor isn't progressing or with that rate. Is there cephalopelvic disproportion? Is there inadequate uterine activity or contractions? Does she need syntocinon? And so therefore, you will then start to look at it. And if in further 4 hours she does not deliver, then you have to take action. Action in the sense that then you institute or you either, if the patient needs to be transported to a better facility, then you do that. So you start thinking about that. So that was the concept of these alert, and as the text shows, this was devised for management of women in Africa. So alert line and action line, an early warning system for transfer, augmentation, or termination of labor, and that increased the quality and regularity of all observations on the fetus and the mother, because it is all recorded, so you know how the labor is progressing. It is inexpensive, effective, practical, and in a variety of different settings. It can be used in developed and developing countries, and effective in preventing prolonged labor, reducing operative intervention, and improving the neonatal outcome. ये हो गया, ये बन गया, ये 94 का था principle. Or active phase of labor, as I said, commences at 3 centimeter, 8 hours. During active labor, 1 centimeter per hour, lag time of 4 hours, etc. So vaginal examination should be performed as infrequently as is compatible with safe practice. Once in 4 hours is recommended, not more frequently. And then this is all therefore, because I'll give this presentation to you on your WhatsApp, and you can read it up and familiarize yourself with this. Although we are no longer using this partograph, but it is important to know its various components, its the principles over which it was based, and what is its significance, so that then if you are using now the new labor care guides, so you would know how it has evolved and developed over a period of time. So WHO partograph of 94 had three components: fetal condition, progress of labor, and maternal condition. And more or less, those are the components which still are practically important. But in addition, there are other considerations now which are been included in labor care guide. So here it is. And in the upper part, this is the fetal heart rate. And so you monitor that between that line of 120 and 160. So if it is going on like that, you don't even have to have a cardiotocography, but you can plot it like that. These are the thicker lines at 160 and 120. And here it says something about liquor, whether it is clear or it is stained, or molding of the head also is given here. And over there, it is the cervical dilatation and the station of the head. This graph is, this area is for contractions per 10 minutes. And this is about the oxytocin, whether it is started and what is the rate of oxytocin and other drugs. And this is monitoring of the mother. So here you monitor the fetus, here you monitor the progress of labor, and here you monitor the mother by temperature, pulse, etc., blood pressure, and then protein, urine temperature here, and urine examination here. So this is a kind of progressive record of the labor, monitoring various aspects of the fetal well-being and maternal assessment, maternal status. So the fetal condition here given in greater detail, highlighted. Then the progress of labor. It was, the study was conducted over 35,000 women in Southeast Asia, and these were the results. So before partograph, what was the situation? Labor over 18 hours, how much percentage? 6.4%, and so on and so forth. Now this is the 94 partograph, and this is alongside that is the new labor care guide, WHO labor care guide. We'll see it in greater detail. ये खत्म हो गया. Now we come to the new care guide. This is a presentation which has been prepared by actually WHO. This is not my presentation. This has been prepared by them, and it is available on net, and you can find it. And the objective of this is a tool for implementing recommendations on intrapartum care for a positive childbirth experience. Again, those various points which I introduced to you earlier. This is an introduction to that. It was developed to improve every woman's experience of childbirth, implementation of intrapartum care recommendations, good quality and evidence-based clinical care guides. You read it up when I forward it to you. Labor care guide has been designed for the care of women and their babies during labor and birth. It includes assessment, observation that are essential for care of all pregnant women, regardless of their risk status, whether it's high risk or otherwise. primarily designed to be used for care of apparently healthy pregnant women and their babies. Women with low risk, high risk women may require additional and specialized monitoring and care. When the woman enters the active, and documentation on this chart starts when the woman enters in the active phase, and now active phase is considered to start with 5 centimeter or more cervical dilatation. All levels of care in health facilities, all levels, which is primary, secondary, and tertiary. So it identifies early complications and contributes to timely referrals. Now, it has 7 components here. We'll be looking at the details of that. One is identifying information about the name, etc., gravity, clarity. Then second is supportive care, when it said that the woman should have a companion, some relative, some friend who is with her, who can provide support to her. Number 3 is care of the baby, so fetal monitoring. Number 4 is care of the woman. Number 5 is progress of labor. 6, any medication. And 7 is shared decision making. Again, you involve the woman and inform her that this is what we think should be done, and are you okay with that? So we do not practice it like that. But even if the forceps has to be applied, you tell the woman that I'm going to apply forceps. And do you agree with that? So if she doesn't agree, you can't apply actually, or you shouldn't apply. So sequential, this is a filled up chart. Section 1 is identification. If you look at the bottom of this slide, it shows what the topmost part, this topmost part of the labor care guide in this slide is been shown here: name, parity, labor onset, active labor diagnosis, date, time, ruptured membranes, time, risk factors. Then comes the supportive care, companion, pain relief, oral fluids, posture. These are the supportive. Companion, yes, no, or posture, supine, on side, etc. And on hourly basis, you would 1, 2, 3, 4, so up to 12 hours, you monitor all these 3, 4. So it just shows that the importance of someone who's a sympathetic companion who would provide emotional support to the woman during her labor. Then what kind of pain relief have you afforded her? It is injectable, it is inhalation, it is epidural. So it is not only that if the facility of epidural is not available, then there shouldn't be any pain relief, at least some injectable kind of, or then explanation, massage, all those kinds of things, because we are not discussing at the moment pain relief, but that is essential. And that kind of attitude that yes, labor is painful and you have to go through that, everyone goes through that, that is not the kind of attitude that we should have. And oral fluids, and nowadays even food is not prohibited. I'll show you briefly some other slides also. Second is care of the baby, fetus. So here you give time and hours, baseline fetal heart, which is if it is more than 160, 110, fetal heart decelerations, amniotic fluid, meconium plus, or position, caput, if there is a caput, or if there is molding. So all those things would be. माइक कर लें जी, आप जरा म्यूट पे कर लें. Then care of the woman, pulse, systolic pressure, diastolic blood pressure, temperature, urine for proteins, acetones. बंद हो सकता है. And then progress of labor, cervical dilatation, 2 hours, 2.5 hours. You would plot it in terms of centimeters and also give time. And here it is descent of the presenting part, which is the vertex. So this will give an impression about the progress of labor. And then medication, oxytocin drip, medicine, other IV fluids, and shared scene assessment plan. We want to continue, we want to augment, we have decided for cesarean section, or we are going to apply Ventouse, etc., because the second stage is also involved in that. So these are the various steps. So assess, record, check reference threshold and plan. So ये है जी labor care guide, और इसको you go and take a copy of that, look at it, familiarize yourself with this, and try to put it into practice as far as possible. There is one more thing that I wanted to show you. This is from American Journal of Obstetrics and Gynecology. It produced a series of evidence-based management of labor in various stages. And this is about the first stage. There are tables. I haven't put in any text. There are various tables, and I would want you to go through those tables. For example, the first is evidence-based recommendation for intervention before labor. This is before labor. I have tried to magnify that, and just the upper portion of that. Antenatal perineal massage with oil for 5 to 10 minutes daily, starting at 34 weeks until labor. Quality of evidence is high, recommendation is strong. Pelvic floor muscle training, starting approximately at 30 to 32 weeks gestation. Education on self-diagnosis of active labor. X-ray pelvimetry. Do not perform X-ray pelvimetry before labor. Sweeping of membranes, starting at 37, 38 weeks. Prediction of spontaneous labor. Transvaginal ultrasound cervical length. This is, well, moderate. But you know, there are quite a few things that we practice, and there are quite a few things that we don't practice. But this is what is recommended when before the labor starts. Not only that, home birth, women with high risk for abnormal outcome should plan to deliver in a hospital. Birth center births, alongside midwife care, continued sport, training birth, teamwork, etc. So you just take those points which are relevant, which you know are practiced here, and which as doctors you should know, and which you should be implementing, and look at that. Then recommendations for intervention during the first stage of labor. Vaginal disinfection, chlorhexidine, not recommended. GBS prophylaxis, we don't do it. Do we do it? But in a way we do it, because all women who are in labor get antibiotics. So what you should be concerned about is the timing of antibiotics. We generally give antibiotics when either they present with rupture of membranes or after the woman has delivered. If we were to take care and give cover for GBS, then we would be giving antibiotics before delivery, at least 4 hours before delivery, so the baby would have some dose of antibiotics transported to the baby, right? So probably what we can do is that if we are to give antibiotics after delivery, we might as well start. And those who are not sensitive to it, we give them a shot of augmentin. तो इस तरह का सोचना और इसको प्रैक्टिस और सजेस्ट करो कि जी हम ये ना करें, इसके बारे में जाके पढ़ो और जाके मुझे बताना कि फिर हम लेबर में किस तरह से शुरू करें. Antibiotics in PROM, prophylactic antibiotics in term PROM with latency longer than 12 hours can be considered. Aromatherapy, immersion in water, nutrition. Oral restriction of fluid or solid food is not recommended. Restriction is not recommended. So you keep giving that. Maternal position, a upright position for women without regional anesthesia is recommended. So they can be up and about. Ambulation should be recommended in the first stage. Bladder catheterization cannot be recommended. Continuous catheterization cannot be recommended. Cervical examination. No, there is no recommended frequency of cervical examination or sweeping of membrane and liver. Partogram, routine use of the partogram is not recommended in liver. This is American Journal, right? Antispasmodic agents are not recommended, amniotomy, etc. So you go through this and you look at the various aspects which are applicable. You can tick mark them and you can make a chart or recommendations for our practices in labor room of Hamid Latif Hospital. So you make a concise thing of that. Then contraindication to induction of labor. This is something which is, this is important. You should know in what situations the labor will not be induced. For example, if there is an abnormal lie, if you are to do cesarean section anyway, then there is no point in that. So more than previous two cesarean, placenta previa, creta, vasa previa, these are obstetrical, then maternal, classical cesarean, fetal indications, any other contraindication. Indications for induction of labor. This is important again. Whereas you should know in which conditions you do not induce, similarly, you should know in which conditions you induce. Intrauterine infection, chorioamnionitis. When do you do that? At detection. Placental abruption, at detection, as soon as you detect. 39 weeks of gestation, because Americans are quite a lot in favor of inducing primary gravitas, particularly at 39 weeks. Because why do they want to do that? Because they want to, after that, the chances of stillbirth become higher. And average stillbirth rate is generally considered to be 0.5 to 0.3%, which would be 3 per 1,000. But even that should be reduced. So that should be reduced. And this is one of the ways by which stillbirth can be reduced. If you induce at 39 weeks, you bring them in, induce them. And when they are obviously induced, then you are monitoring the labor as recommended. Maternal indications for induction, chronic hypertension, no medication at 39 to almost 40 weeks, because 39.6 is 40 weeks. Chronic hypertension controlled on medicine, 37 weeks onwards. Chronic hypertension difficult to control, 36 to 38 weeks. So on. Pre-eclampsia, eclampsia, diabetes, pre-gestational, well-controlled diabetes, intrahepatic cholestasis, more than 100, less than 100, previous stillbirth, PROM, IUGR, singleton, otherwise uncomplicated, normal, umbilical artery Doppler, etc. So these are the indications for induction of labor. This continues with twins, etc. So this is a long list of those indications and when to do the induction of labor. This is in the chart form from 31, 32, 33. This is these are the weeks. This is very early. That's why it is labeled or colored red. And here 39 weeks, it is colored green, which means it is comparatively, it's safer. This is gray zone here. So pre-eclampsia severe and gestational diabetes, pre-diabetes, poorly controlled. So in those, you can start considering an induction depending upon the status of the disease from 34 weeks onwards. So this is that. And this is suggested gestational age for induction of labor for selected. This is graphical representation. And this is proposed algorithm for induction in women with less than 3 centimeters cervical dilation. And here they recommend Foley's catheter with 60 to 80 milliliters single balloon for 12 hours. We don't do that. But I would recommend that you start taking up on those who have to write some synopsis for induction of labor. You start doing this and follow this algorithm and find out how much Foley's catheter helps in that. So there is no contraindication to misoprostol, and the dosage of misoprostol, 25 micrograms, 2 to 4 hourly. Every 2 to 4 hours, or 50 microgram every 4 to 6 hours. So you have this reference in which you can give 50 micrograms and you can start with that. Oxytocin infusion. So with all these precautions. Then possible algorithm for twin singleton term vertex pregnancy with Bishop score less than 6 or cervix less than 3 centimeter dilated. React. ये आप देखो इसको, ये तो दोबारा से वही आ गया. Indication for intrapartum antibiotic prophylaxis to prevent neonatal GBS early onset sepsis. ये भी है, ये चार्ट भी देखो, ये बनाओ. Right? So I'll forward to you these 3 presentations. आप इनको पढ़ो, देखो, and then we will talk about management of labor, the mechanism, etc. We have already discussed, but we will speak about it. A summary of all these 3. I would want you to volunteer करो, कोई 2 लड़कियां वो करके तो इसकी एक finalized summary बनाओ कि what are the recommendations for us in this hospital. It will be different for all those. हाँ जी, अब questions. अब उनके वो माइक ऑन कर दें, देख लें क्वेश्चंस अगर हैं तो. माइक ऑन है. क्या तो उनके साथ बात करो ना फिर. आप
हम तो पेशेंट को देते हैं.
नहीं, इस तरह से नहीं है. You see, we have to, जब एक टीम काम कर रही है ना, for the patient we are one team. Obstetricians, anesthetists, nurses, all we are one team. So we need to project ourselves like that we are one team, and we have to incorporate those things in such a fashion that we know our viewpoint. So no questions, right? चलें जी.
एक क्वेश्चन आया है.
हाँ.
Patient starts vomiting in active labor when we give solids.
Patient starts vomiting in active labor when we give a solid. Well, yes, of course. That doesn't mean that we have to force feed them. And about the solids also, you don't give pizza, for example, because that's gastric emptying time is slow, and that's not something which is easily digestible. So you give food which is easily digestible, and say some biscuits or a piece of bread or something like that, simple, with fluids. And if, of course, there is vomiting, even if the patient is not in labor, even if it is not a pregnant woman, someone who is vomiting is not given food. So wherever there is contraindication to give food, or in those cases in which we expect that the woman will have shortly, in short period of time, she can have, or there may be need of general anesthesia, you don't give food for that. So it is not across board that the recommendation is that you, the recommendation is that you don't withhold food, solids or liquids. So you give those semi-solids, and then that's why I said that we need to formulate our own recommendation, that what would be the best in consultation with our anesthesia department here. But generally speaking, you can refer to this paper or this reference, that this is been said like that. And remember, once again, despite this repetition thing, that you do not give those kinds of foods which will remain stuck in the abdomen for a longer period of time. You just give something which is easily digestible. GDM on insulin, अब आपने वो अगर कहा है तो फिर अब उसको हम देख लेते हैं कि जैसे.
सर एक बात पूछी थी.
जी
ये सर्वाइकल डायलिटेशन का टाइम बहुत ज्यादा है इस पार्टोग्राम में। जैसे 5 सेंटीमीटर पे 6 और है, वैसे हम 1 सेंटीमीटर पर और लेते हैं,
हम्म
तो 6 पे 5 और है और 7 पे, मतलब इतनी देर वेट कर सकते हैं इसी।
the first thing is no, not necessary to do ARM. First thing is that theory of 1 centimeter per hour, that is not now generally accepted, and not particularly in the new labor care guide. That was the previous, partograph, which started in 50s or 60s and which continued till 90s and till recently. That was generally the impression. But most of the people who worked on that, they thought that it was unrealistic, comparatively unrealistic. But that generally was a good guide in the sense that if there was a delay, because we see so many times that some women, they make rapid progress, and just in 3 hours or 2 hours, from 4 or 5 centimeters, they are fully dilated. And on the other hand, there would be some who may take about 6 hours, 7 hours, or 8 hours. So long as there is progress, there is dilatation, gradual dilatation, there is gradual effacement, there is gradual descent of the presenting part, then you continue monitoring them. And the newer labor care guide does not specify that it is 1 centimeter per hour, but you again plot and see what is how is it progressing, and then find out if there is an abnormality. 2 hours to 1 hour abnormal to see liquor color. No, if there is an indication like that, you see, you should have, I'll bring to you a poem which was written by a student of Ian Donald when he was telling them or lecturing them on the benefits of keeping the membranes intact. One of the, if we are talking about membranes, so the advantage of keeping the membranes intact is that there is no ascent of pathogens to the fetus. The fetus remains in that protected environment of it. The bulging bag of membranes is a good dilator of the cervix, because even if the head is high, the bag of membranes produces a kind of equal pressure all around over the cervix, and is a dilator of that. And you are generally safe. You think that the labor is safe, the baby is safe, so long as the membranes are intact. On the other hand, if you have some doubts about and you want to confirm that whether the fetus is having distress, for example, the CTG is non-reassuring, or if you do not have the facility of CTG, you find that the fetal heart is dipping or is not doing very well on auscultation, then of course, if you want to see the liquor, then you would rupture the membranes, depending where the fetal head is. If it is very high, then you know that there would be the possibility of prolapse of cord. So keeping that in mind, so you fulfill the requirements, you make sure that it is going to be more informative than it is than it can be of some harm. So you do ARM, even if it is you are doing it for the sake of expediting labor. So one is to look at the color of the liquor. The second is to expedite the rate of labor, or improve the contractions, because this was one of the, before misoprostol, etc., this was one of the methods by which labor was induced, at the rupture of forewaters or rupture of hindwaters. Can anyone name the catheter by which the hindwaters were ruptured? There was a metallic catheter by which hindwaters used to be ruptured. That used to be called Drew-Smythe catheter. चलो जी, अगले हफ्ते हम इसी के ऊपर बात करेंगे फिर मजीद, ठीक है? थैंक यू वेरी मच। हाँ, चलो मैं भी करता हूँ। चलो मैं करूंगा, ये करता हूँ मैं फिर, ठीक है। ओके।